Hi, I'm Dr. Sheikh Riyaz Ahmed. I'm consultant urology, uro-oncology, and renal transplantation at Amandeep BR Medicity Hospital. So, I will be talking about treatment options in BHP.
Who all are at a greater risk of developing benign prostatic hyperplasia.
First and the foremost risk factor for BHP is the age. As we see, as a patient ages more than 50 years of age, they are having high risk of having BHP. Roughly, if we go into the incidence and the prevalence, all about 60% of patients above 60 years of age will have BHP histologically, and about 80% of patients above 80 years of age will have BHP. So, as age progresses, the proportion of BHP increases.
What are the various tests which can help diagnose benign prostatic hyperplasia?
So, as far as the evaluation of a patient with BHP goes, it starts with a complete history about the obstructive and the storage LUTs. Obstructive LUTs means decrease in flow rate, intermittency, straining during urination, sense of incomplete voiding post the micturition or post micturition dribbling. And as far as the storage LUTs are concerned, these includes increase in frequency of micturition. A patient will have nocturia or patient will have urgency with or without urge incontinence. Then there are multiple other symptoms like patient can have hematuria, patient can have weak stream. These are all symptoms related to BHP. Once we enumerate the complete history, then we go to the physical examination. It includes a focused genitourinary examination, suprapubic examination, and then the digital rectal examination. And to complement all these PS, we're doing an ultrasound, abdomen and pelvis. In that, we are really interested in knowing the kidney, ureter, and bladder, plus prostate size, bladder capacity, post-void residual urine, and the medial lobe. Then there are some dedicated parameters on ultrasound which we will like to enumerate. They include PICAR, they include the prostatic urethral length, and they include the bladder wall thickness. In addition, we would like to complement our all these workup with uroflowmetry. And in certain patients where we suspect underactive bladder, we can do urodynamic study.
Is there any association of benign prostatic hyperplasia and prostate cancer?
Yes, there is an association with BHP and prostatic cancer. In all the patients in the age group of 50 to 70, mostly as far as the guidelines like the AUA 2025 or NCCN 2025 or the European guidelines go, most of them talk in a single voice that we should be doing screening, especially PSA screening, 2 to 4 yearly, starting from 50 years to the 70 years, or in those patients who are high risk like the African Americans or who have ancestors with prostatic cancer, we start this screening from 45 years of age. There's no need to screen the patients above 70 years of age. So it has been found that patients, if we take 100 patients with BHP, there is a proportion of about 5 to 6% of patients who harbor a hidden prostatic cancer.
What are the treatment options available for patients with benign prostatic hyperplasia?
As far as the treatment options are concerned, it depends upon the patient. We categorize our patients into two groups. One group is those patients who have definite indication for intervention. In that, we cannot follow a ladder approach. Ideally, we would like to start with the ladder approach. Ladder approach is we start with the medical management first, and then we go to the more invasive one. Those patients who are not clear-cut indication for surgery, we would like to start with medications. It depends upon the symptom score of the patient and the size of the prostate. Any patient who has a mild to moderate symptom score plus prostate is less than 40 grams, we start with a single drug. And choice of drug depends upon the age of the patient. In younger patients who are 50 or less than 50, we start with alpha-zocin because we are mostly concerned for their erectile function or sexual function. As we go towards the elderly patients, we can start with sildosin, tamsulosin, depending upon the age and severity of the symptoms. And patients who have severe symptoms or the prostate is more than 40 grams, we usually start with a combination of alpha blockers with 5 alpha reductase inhibitors. So, firstly, we start with the medical management. Those patients who respond to the medical management, we would like to continue the medical management, but there are definite indications where we have to go for more invasive type of management. Those are the patients in which the medical management has failed after 6 months, or there's an increase in the score of 4. If a patient is on treatment and there's a score increase by 4 points, then we would like to start with some intervention. And as far as the interventions are concerned, at present we have they are least invasive to the more invasive options. Those patients who are low risk patients, we would like to categorize them in according to the weight of the prostate into three categories. Patients with less than 30 grams of prostate, patients with prostate between 30 and 80, and those patients who have prostate greater than 80 grams. Patients with less than 30 grams of prostate, most of the times we will do TUIP, that means transurethral incision of prostate, or in certain patients we can do bipolar or monopolar TURP. Patients with a prostate of 30 to 80 grams, we will like to do monopolar or bipolar TURP, or we can use lasers like holmium YAG laser, or we can use thulium fiber laser or thulium laser, depending upon whatever the facilities are available. And as far as the bigger prostates are concerned, we may have to resort to open or laparoscopic or robotic prostatectomy. And those patients who are unfit for surgery, we have the latest advancements like the MIST, in that we have optolume system, or we have Zoom, we have aquablation, we have iTints. Those have really revolutionized. And these MIST have one more specific indications. The most common indication is the high risk patient, and in addition, the second indication are the young patients where we are mostly concerned to preserve the sexual function. In that also we can use iTints, optolume system, or Resume or aquablation. Thank you.